Great. So today I'm going to talk to all of you guys about what I call the art of creating an ear. We'll go into why I call it that, but I'd like to start by just telling you a little bit about myself and how I got to be here. Obviously starts with my family. All of these guys are here, as are my parents, and I owe these guys a lot. This career definitely is intense and time intensive, and some of my time for patients may take away from my time from my family, and they have never once made me feel guilty about that. And they are here, they work these conferences, and sell t-shirts and do whatever we need and run errands. So you guys, I love you and thank you very much. So this was not a direct path for me. It was very circuitous, and I just didn't plan a career in medicine at all. So I was a California girl. I was born and raised in Los Angeles, and once you're born and raised in LA, you really don't want to leave California. So I ended up going to college at Berkeley, and to my great surprise, despite having a father that was an architect and a mother that was a nurse, I fell in love with architecture, and I studied this during college and was absolutely fascinated by design and creativity and visual three-dimensional imagining of creative spaces. So I got towards the end of my college career, and I can blame my husband for this because he's the one who made me think maybe there's something more that you want out of your career, because that connection to people wasn't there. So I ended up changing gears and went back to post-bac program to get pre-med requirements and decided to go into medicine. And I didn't have to travel too far happily. I went across the bay at Stanford. And then interestingly, when I got to medical school, I kind of longed for architecture a little bit. But that changed once I saw this little baby when I was a medical student. And I was like, oh my God, the art is right here in medicine. If you've ever watched a cleft surgery, on a video or anything, this is sculpting with live tissue. It's amazing. And I was sold, going to be a pediatric plastic surgeon, and that path didn't veer from there. So after medical school, I did my residency and training at USC, and then did a fellowship in pediatric and craniofacial plastic surgery at Children's Hospital LA, and that just happened to be one of these centers that focused on microtia. And one of the first times I ever saw a patient with microtia, I mean, as many of you in this room know, you fall in love with these little kids, and it just became my passion. So I started out moving back down to Los Angeles. Well, I was in LA, but I ended up working at several hospitals: Children's Hospital, Cedars-Sinai, and then Shriners Hospital for Children. And I was doing general pediatric plastics, but primarily focused on ear. And then it just became clear that my path and my passion was ears. And so I left for private practice in 2012 so I could just dedicate myself nearly exclusively to ear reconstruction. So if you do not have someone you love who is born with an ear issue, I don't think you understand how much we take an ear for granted. But the really funny thing about ears is that they are, you really don't notice an ear unless there is something different about it. So when I think about what do I want to give my patients, my ideal ear is actually one that nobody ever notices. So it sounds like a funny contradiction, but if you can match that so-called normal side as close as possible, then maybe nobody will ever notice the ears. But a couple years ago, there was some media press about children that were getting cosmetic surgery for prominent ears, and a lot of bullying going on with these kids. And this is real, and this is the world we live in. And I never call either ear reconstruction or even a prominent ear that gets corrected, cosmetic surgery. It's actually, you know, most of the people in the world are born with ears that look very typical, and if you're not, you should be reconstructed. And what we end up learning, which I read this quote in a psychology journal, is just how significant the psychologic component of microtia or ear issues are. And it just says humans visually understand when facial features appear in balance, and few, if any, features elicit such negative responses as ears that are prominent, overly large, or misshapen. So this is just a beautiful child, but I think when you look at this picture, she's a patient of mine, it is sort of the first thing that strikes you is that her ears are prominent, perhaps more prominent than we're used to seeing. And children like this wear their hair down, and girls like this, they wear their hair down, but their ear actually pops through their hair, and it is bothersome to them. So with honestly just a couple hours in an operating room and 30 minutes later you're back home, you can transform this child into all you really notice is that beautiful face. And the ears become ideal in that you don't even notice them. So today I have two goals, essentially. I want to answer the questions that parents most often ask me, but in addition, since you're sitting there and many of you are at the beginning of this journey, I also want to answer questions that I think you should ask of physicians or ask about this process that we're going through. So we know microtia literally translates into being a small ear, and atresia means that you do not have an ear canal. And it's this spectrum, and every kid I saw yesterday was a little bit different, and that little difference, in my mind, I'm analyzing that anatomy and figuring out how's my surgery going to be different to respond to the different patient examinations that I'm seeing. And I guess by now everybody's seen this grading system, and we put it up multiple times just because we want you to be familiar that this is how we refer to kids in operative notes and when we're describing their examinations. And so clearly we don't operate very commonly on grade 1. You can if it's really significant. Grades 2 and 3 that you see there are clearly the most common and most of what we see here. Grade 4, which is really no ear, no cartilage, and just maybe the tiniest bit of skin, they're clearly the most difficult. This is a little boy that you're gonna see in a surprise a little bit later, and that's all I'm gonna say about it. But he has bilateral microtia, and we all sitting in this room wish we knew the answer to this question. What causes microtia? And apart from some very rare, either genetic or drug-induced things that can cause microtia, the truth is we really don't know what happened. And so, yes, there's going to be a genetic component, and yes, an environmental component, but how did this occur? We're not exactly sure. This is one of my little patients over here who is born in Ecuador, and she's snuggling with her grandfather. And interestingly, her grandfather had one of the first rib cartilage ears from a very famous United States surgeon, now retired, Dr. Burt Brent. And you can see he has a Baja, and she similarly, we did MedPOR at that time, Porous Implant Ear Reconstruction, and a Baja. So I sometimes feel like this is the most important slide. We all have this. Maybe moms seem to have it in excess, that anything your child is struggling with, somehow it's our fault. But I think all of the surgeons that are here at this conference really want you to understand this point. Nothing you did led to this. It's just critical that you don't carry that guilt, because it's not true, so do not blame yourself. We just need to leave that at the door. We'll move on now. So a natural ear, okay, I'm a little obsessive. I study this way too much, but I just want you to really appreciate the complexity. This is sort of where we start. So we've got this rim, the helix, we've got the antihelix, which is the central, what we call Y-shaped portion that gives structural support to the rim. The tragus is this little piece of cartilage that kind of hides your canal because you're not going to see it, and the earlobe. But when I'm reconstructing an ear, I'm thinking about a lot more things. I'm thinking about the complexities of the upper ear. Where are those shadows? Where are those highlights? How do we get that definition? I'm thinking of the bowl and how each part of the bowl it's not just a hole, there's different structures that require, and they have different shades of shadowing, darkest at the top, lighter in the middle, a shadow behind the tragus for the canal. And then there's a lot more, and you go, whoa, there is a lot going on. So when I tell you my surgeries take 8 to 10 hours, this is kind of why. We'll go into that. But really, I think if you polled plastic surgeons and perhaps otolaryngologists, most all of us agree that creating an ear is one of the most challenging things we do in all of plastic surgery. I'm going to intersperse a little bit of my philosophy here throughout this talk, but this is just one of my staples, and I feel like it's probably why I feel like I had a calling towards making ears, coming from a background in art and architecture, is because every day I go into that operating room, I am like in my Zen moment of creating a sculpture. I have, in many cases, I have the opposite ear to match, and I just am really focused for a very long time on how do we elevate this art? How do we get better? There is room for improvement. I am the first to tell you that, but I plan for the next 15 or 20 years, like, trying to get there. So options for microtia treatment. Obviously, we know that we don't have to do reconstruction, and it's up to every family to decide what their preference or timing, or if they even want to do ear reconstruction. And the prosthetic ear, awesome for certain circumstances, for sure, like failed rib cartilage or failed MedPOR or SUPOR ear reconstructions. You can remove that tissue and create an amazing similar appearance. For children, toddlers, it's a little difficult daily putting it on, taking it off, the risk that it could fall off, multiple prosthetics noticed. So it's great in certain circumstances. But then of the surgical options, we have these two fairly different approaches, both kind of framework-based. So you have a rib cartilage framework and the porous implant ear reconstruction as the framework. So for the rest of the talk, just to make it easy, I refer to my technique as PIER. So you can see we're not there yet in terms of making an exact likeness to this incredibly complex ear that I showed you. But what are those differences between the two, rib graft and PIER surgery? So actually, we'll start with the similarities because they do have some things similar. Both techniques really require this beautiful, hairless, perfect colored skin that is surrounding the microtia remnant as the front coverage for the ear. And then we have to cover the back of the ear as well. In the PIER technique all at the same time, and in the rib technique, I think at a later stage, you get skin grafts from another part of the body. But clearly there are differences in that porous polyethylene, the material of SUPOR and MedPOR, is a man-made synthetic substance, and rib cartilage obviously comes from the child. So these, because they're different techniques, are created in a different way. The PIER is three-dimensional, and because of the incredible strength of this material and the way that it is created in a mold, you can make it very thin and delicate, and yet it retains strength. However, rib cartilage, because it's this natural material, it doesn't have quite the same strength, and you see that it's bendable, and so in order to prevent scar tissue from having those effects on rib and altering the framework, it does have to be a little more substantial and built a little more two-dimensional in the beginning because it's fitting into that tight pocket under the skin. So what is covering these frameworks? So the magic and why the PIER technique works is this, sorry, I didn't give you a warning that there's something graphic, but you can see it right there. My apologies. But this is red because it's got arteries and veins running through it as well as nerves, and it is this rich, rich, almost transparent, what we call a flap, and that's what covers this implant, this living membrane. So if you look at that center picture, you can see that we put suction on it, similarly to cartilage technique as well, and you see the detail of the framework. And then it's covered with skin grafts. And here you can see the rib cartilage. This is a wonderful surgeon in Canada who gave me these slides to use, and this is her technique and putting in this implant, or sorry, framework into her skin pocket there. And after suction is applied with that drain, it takes the form of the implant or framework that she made. So this is my opinion or my conclusion. I have done both techniques. The last time I did a rib cartilage was 2010, and I do not do that surgery or offer that surgery anymore. I am not an expert by any means in the rib cartilage technique, but my experience with it led me to the conclusion that that challenge for me of getting this cartilage framework that can withstand those forces of scar contraction that the body naturally has, and limits that ability for me to get that technique to look as delicate as I would like. So if I go through why I prefer this technique or why I made that decision, I sort of looked at my goals for my patients, and went through that process of analysis. So I feel like in terms of getting a realistic and detailed appearance, which is clearly the goal, that I am much more able to do that with the PIER technique. This is a kid from last year, and I've spent a lot more time in the last year developing, strangely enough, the back of the ear. And we'll go into that a little bit more, but when you're making a sculpture, it doesn't make sense to just sculpt the front of the ear. We think that, but then families ask questions about, what's going on here in the back, and I'm like, I kind of ignored the back for a long time, so I don't do that anymore, and I feel like I can get this three-dimensionality I'm looking for with this technique. In terms of getting symmetry right away, not that that is so critical, but it's rewarding for me to have right after surgery a patient able to wear glasses, have their ear stick out similar to the opposite side, which can be done in this technique. I do appreciate that most of these patients only require one surgery. The ones that require a revisional surgery are typically those with more challenging anatomy, grade 4 microtias, significant hemifacial microsomia, or patients with syndromes. But the overwhelming majority of my patients only require one operation. I also like that you don't have to be in a hospital. For me, one of those goals, since I am working with an implant, is infection control. And I will talk a little bit later about how we have refined how to get the most pristine and sterile environment so that we don't have so many issues that we have to worry about with these implants. I really like, as a mom, just the goal for me, not necessarily that it has to be for you, but getting a kid reconstructed before they go to school. I think the PIER surgery generally has very minimal pain, and generally my belief or understanding is that rib cartilage has a little more pain. However, I'm not sure if all rib cartilage surgeons are so focused on like the latest anesthetic things that we can do to minimize pain. So we've trended down. I think both actually techniques have trended down in terms of pain medication a little bit in response to the opioid crisis in America, but I am now transitioning to not using opioids for or prescription pain drugs. We like give you a prescription if you need it, but really many of our kids are now just using Tylenol. Adaptable as technology advances, this is actually really important to me. I can't speak for how adaptable rib cartilage is because I'm not an expert in that technique, and it is complicated and technically quite challenging, and so I would leave that to the cartilage surgeons to respond to. But from a PIER standpoint, the thing you have to remember is we're creating most of this ear from your child's own tissues. They're theirs forever. They are not going away. So literally, if some wonderful new implant comes along and it's so significantly better than what we were doing today, with no new incision, no new skin graft, and no new flap, you can replace this implant in a relatively simple outpatient surgery and put in whatever wonderful thing may come down the pike in 5 or 10 years. Safe and long-lasting is obviously the ultimate goal, and clearly both procedures do that. So my clear preference obviously is PIER, and so that's what we'll be discussing the rest of the talk. The basics are you start with this implant as the structural support, and your body's own tissues cover it to provide durability and stability. But what is this made of? It's actually a high-density porous polyethylene. It's been around for a very long time, 1970s, used in the body many, many different places for many types of surgeons, but certainly a lot in the craniofacial area. It was first used commercially in the 1980s, and you'll see the implants in our appointments. They're extremely light. Half of it is actually air, and this actual porous polyethylene is considered the least reactive or most inert material by the FDA. It has a very long track record of success, and the reason that it is so successful in all these different areas of the body, orbit and nose and chin and jaw, is because of this unique quality of having these holes or pores. They were very specifically designed to encourage the body's blood vessels to grow in, or tissue to grow in. So we call that tissue integration, and without that, none of this would work. It's actually true, I've seen it in the OR on occasion. If you had a reason to replace an implant, I've cut the implant in half, looked, and you see bleeding from inside the implant because those tissues have grown in. So it's not a theory, it's an actual thing that we see occurring and have proven. So that's called biocompatible, and allows it to be, the actual polyethylene allows the framework to be very thin but very, very strong. But the key, and this just will not work if you don't have healthy, well vascularized tissue covering it. So this is actually the first porous implant that was ever done in a patient. It was way back in 1982 in Germany, and Dr. Berghaus gave me these slides very kindly to show his very first patient. And then MedPOR came along, first performed in the United States in 1991, so quite a long track record in and of itself, but the early experience was quite variable. Some fantastic, many okay, some really, really poor results. And the complication rates, because we hadn't figured out how exactly to use this material, were quite high in those early series. And certainly it's technically challenging, so it sort of was the black sheep of ear reconstruction for the longest time. And then a wonderful company that somewhat grew out of MedPOR came along called Supor, and Supor had several advantages in my mind, and so I started using that and did the world's first Supor ear reconstruction back in March of 2015, and this was the first child to ever get a Supor ear. She's living in Colombia. So if you look on the outside, these two Supor and MedPOR products look very similar. And indeed, they're both the same exact material, the same basic shape. FDA looks at them the same. And interestingly enough, the developers of Supor came from MedPOR. And so they took all that expertise, and multiple employees helped form this new group, and they upped their game, in my opinion. So what are those differences? Well, the Supor rim is more flexible, and you can visit the table over here and take a look at how that rim is more flexible than a MedPOR rim. And it's clearly in my hands much easier to carve. It's smoother on the surface, but the knife or the needle goes through very beautifully. And I find it, with that, easier to shape the Supor. But really, this last point is what is so special about Supor, and it all has to do with the leader of that company. But they do have trade secrets that basically help me execute what I want to do for this technique. So I've alluded to the fact that it's a very long day for me to make one of these ears, so I figured, why don't I just take you through a day in the OR and you can figure out what I'm doing during all those hours. I'm an early riser. So since I want to see my kids at dinner time, we start surgery at 6 a.m. So I meet my patient. This is our about 1-year-old facility. This OR Cove Surgery Center was built exclusively for these patients, for you sitting in this room. No other surgeon or type of surgery is done in these walls, so we literally can control this environment immaculately. And this is our patient that I want you to meet, who comes with his friend. And when I see him in the morning, the first thing I do is I draw the ear on his typical side, and then we're gonna twist it and figure out, well, where is that gonna best fit, and figure out our symmetry for our planning. So by 6 a.m., I'm in the OR carving and making my implant, and at the same time, your child is being wheeled in and worked on with anesthesia to get all prepared for surgery. So that implant is customized, and this I would say is my, the technique I've used for about, since 2013 I started this technique, I would say. So, oops, did that video play? Yes? Oh, I was supposed to talk about it. Anyways, it's 2 pieces and we can customize it to any size. And then we solder or melt the porous implant material to make it stronger. So what it looks like when it's done is this. Oh, okay. There we go. So it's 3-dimensional, still quite thin. You can see where we melted pieces of the Supor material to create this shape and make it much, much stronger than it was prior to 2013. So by 7 a.m., our child is prepared and ready for me to do surgical planning, and this is certainly a critical part of the case. And so we first draw the ear when the child's sleeping, and we figure out how to create an adult-sized ear, because clearly this ear is not going to grow, so we make it adult-sized. We transplant the symmetric position, and then we go through marking all the different arteries, which are those dots, and the veins, which you can see here. And this pattern is unique for every kid, so you don't want to treat every kid the same. It used to be that we always did it the same way every time, and I realized that if you stare at that anatomy and you figure it out, you can design a flap, which is the tissue that is the living membrane based on these blood vessels, specific for each child. So what is that flap? We call it a living membrane of tissue that's in between your scalp on the outside and your skull on the inside. And the dissection of that flap is clearly the most important part of the day. If you do not do this flap pretty perfectly, you will have issues. And that's one of the reasons I think there's a lot of criticism of the technique is it doesn't leave much room for error. So this just shows you that between the skin and the fat, and between the muscle and the bone, in between those 2 areas, you have these really important blood vessels that you see here, and that tissue that you see with those blue dots is what we call the fascia or the flap. And so when we design this customized to the child, instead of doing what would be a traditional flap that's in all of the books and such, I look at these arteries and veins and I only see 2 arteries and 1 vein. But let's say I decide to change this to be more optimized, so we have the best chance of success with the best blood supply. Well, I can see on this, if I designed it here, I would have 3 arteries and 2 veins, and clearly that's going to be a more vascular flap. So that's what I did for this child. So at 8 a.m., we start taking this flap out. And in 2006, I developed the first flap harvest with no scalp scars. So we just use this incision, and we're able to retrieve that very large flap that we're drawing nearly to the top of the head with no scars in the scalp. So I have gone on to teach that to other surgeons, and I think I'm hoping that this becomes the standard of care because it's much better for the child not to have scars. So what we do next is we basically preserve that purple area that's not touched, because that's where all the blood supply is coming from. But all the area that's salmon colored, we take out by like elevating the scalp, and I look through this tiny tunnel window with a special light and a special retractor, and we're able to take out all of this tissue and bring it out through that incision. And graphic slide next, the flap actually is transparent. So you can see through it these blood vessels and how rich this blood supply is. And so the key to the successes I'm going to reiterate here for you guys is how that living membrane works. And like I said, if it's done perfectly, you'll have a healthy, stable ear. So by 9:30, we're off to getting skin. So we've got our implant done, we've made our flap to cover the implant, and now we have to get skin. So here we have oh, you know what? I'm so sorry. I don't see the videos, so I have to turn around. But you can see that in this boy, we decided to take skin from the arm, and that's because that skin is able to be considered full thickness, and it's a very close color match to the ear skin, and it's used for the back. We already talked about the front is used from the skin around that microtia ear. Here we have a tummy incision and an upper arm incision. Girls get tummies. Most, but not all boys get arms. And then at 10:30 in the morning, we're still getting more skin grafts, so we usually don't have enough to cover the whole front of the ear, so we borrow some from the opposite ear. And to do that, that's an incision that's actually behind the ear. There's no incisions made in the front of the ear, but we're able to get just enough skin to make the ear reconstruction look a beautiful, perfect color on the front. So this is the operating room that we built for these children. It is unique because there are not too many glass-walled operating rooms, but I suppose the architect in me said, I'm going to be spending so much time in this room, I want it to be beautiful, and it puts me in a really good mood. So between about 11:45 and 12, I do take my potty break, I eat a little protein, and I always make everybody look at the shadows of the trees because it's really cool. Now while I'm doing that, you guys are chilling in the lobby. The lobby for this surgery center has a queen-size bed, blankets, we've got drinks for you guys, we've got Netflix that you'll be watching for a very long time, and we make it like your living room. It is all yours. Nobody else walks into that room. So that's part of a different approach you just don't see in every hospital. So here's our patient, Thomas, and it's about, it says 12 p.m. to question mark. This is the art. The putting together of this ear is absolutely where I go into that Zen mode, and I'm like, how do we get the best scars? Where do we place them? How do we make sure the color looks best? How do we get perfect symmetry? Or that's our goal if we can. So you can see this is the flap in place over the implant, and there's a drain you can see right there. And we can create suction on this ear to get ready to put our skin grafts on top after that. And then here you can see these, oh, I'm sorry, there's our implant. Okay, forgive me. There's our flap suctioning down. There we are at the end of the case. And here shows where the skin grafts came from. This top skin graft came from behind the opposite ear. This skin graft came from where the microtia was. And then these other two areas that you see are from the arm in this patient's case and covering around the back. And you can see as the skin grafts heal, this is only 7 weeks after, but those different colors start to blend because of how we sew them together and where we place them. Here's our patient immediately after surgery, minutes essentially, and you can see he's eating a popsicle. Our patients go home just 1 hour after surgery, so it's considered outpatient and they don't have too much pain, so that helps. Our patients from the United States will stay in LA for 2 weeks, and if you're international, you'll stay for 4 weeks in Los Angeles. But there's a lot of fun things to do in LA. It's not a bad place to spend a couple weeks, and so our little patient Thomas, before I even saw him the first time after surgery, made it to his first trip to Disneyland. And here he is, day 7, when we take off these incredibly elaborate dressings that protect your ear from just about any child and what they can do, and then he gets to see his ear for the first time. We then protect it all up. So we take that post-op care very seriously, and we do want to bling out these cups so that these kids enjoy wearing them. And now I hear more from parents that they don't want to take it off, or when we're done with the cup, they're like, where's my next cup? And so we really also make the animals have their ear protection as well. So the post-op care, you get a bag. It contains everything you're going to need for post-op care, and we are in annoyingly constant communication with you after you leave Los Angeles. It's a couple months that we are going to be dictating what to do to this ear, how to clean it, where to put what ointment, etc. But 6 weeks after surgery, you're going to be back to all of your normal activities, and we have tons and tons of Microtia athletes. One patient in particular will blow you away. This is a patient who 8 weeks after surgery participated in the World Games for tumbling. So if you think Microtia is going to stop your kid from whatever, I mean, think twice. He came to me in his early 20s for surgery, so he did wait or delay having this surgery, but there's just no stopping these kids. They are amazing. So I want to go through some typical results for patients in my practice, and we'll start with grade 2 Microtia. Here's a teenager before and after her surgery, from a couple different views. So if you remember grade 2, they have like a canal, a tragus, and an earlobe, so they're probably the easiest type of surgery for me to reconstruct. Close-up views and comparison views, those are all very critical. But the most common we would see is a grade 3 Microtia, and all of you get to meet this young lady because she happens to have traveled here from Nebraska. Thank you. And so this adorable cutie, Lauren, here she is before and after surgery. And this is 6 months after her surgery. Her dad, thank you, Michael, is an awesome photographer and would send me all kinds of pictures. And so I'm able to get good follow-up from many of my patients. So here you can see a close-up of her ear. I guess I put one of my slides from China in here, so that just says 6 months after surgery, comparison views. Sorry. Moving on. Some of our patients have what we call a prominent ear, as you saw before. So this ear subtly sticks out a little bit more than, let's say, a typical or average ear. So at the time that we do surgery, we try to set that back a little bit, as you can see here. And here he is before and after, a close-up view, a comparison view to his opposite side, and here's a little video of him spinning around, because really 360-degree view is the best way to assess symmetry for these children. So now we move to the hardest type of Microtia reconstruction. This is called anotia. There's no ear. And this is my patient, and just a little bit of skin. But do you notice this is what we refer to when we say a very low hairline? And I will show you an intraoperative planning picture right here. So you can see that this is where I'm putting her ear. This is the hardest, that I will definitely say, but we obviously can't have the ear on hair. So this technique allows us to be able to put the ear wherever it needs to go. We're not dependent on anything for positioning except symmetry to the opposite side. This child has her post-op result here, and we only did one operation. I will not say that's typical for an anoscia, because I would always tell a parent that will require two. This was just the happy case where she did not. So here's her front do. Can you see the sass? The blue streak in the hair, love it. She is not lacking confidence. And here you can see her from her 3/4 view and her close-up view. You can see, even though she had anoscia, this is one of the hardest things, but little girls want earrings. They really, really, really do, especially if their mom has earrings. And so to get a single-stage anoscia reconstruction with pierced ears is my challenge, but I love it, and I'm very happy that we were able to do that for here. There's her comparison view. Children with bilateral microtia, also, we have many patients. It's only 5% of the microtia population, 5 to 9%, but this technique sort of lends itself to, if we can just do 2 surgeries, potentially 2 outpatient surgeries, and get your kid 2 ears, it's pretty exciting. So this is Donna. She's from Ecuador, and we did 1 surgery on each ear and able to get her, nice projection before and after. And her ears pierced, of course. So I saw a lot of patients with hemifacial microsomia, and that is a special case for children with microtia, and also a special challenge. And I think that this technique particularly lends itself to that challenge, and I'll show you how we do that. So this little girl is adorable, and I'm gonna go through an exercise with you guys, where we're gonna look at her from the top, which is the best view to see both ears. And if we split right down the middle and mirror image her side that you're looking at on the right side of the screen to the opposite side, you'll see what's considered perfect symmetry, right? So we'll outline that perfect symmetry and go back to our original picture and look at what we are trying to accomplish. That is an incredible challenge. And it's not going to end up being perfect. You have to adjust, since every little tissue is smaller, the bone, the muscle, the skin, and the soft tissue. You have to make some adjustments, but in the front view, since you can't see those dimensions, you would like her to look symmetric. So here's that, area that we're going to try to make up for. So now that's our distance X, where is our goal. And here she is after her reconstruction, where I feel like we came close to our goal, but you can see they're obviously not perfectly symmetric. But that strong implant is able to overcome these issues with asymmetry with hemifacial microsomia. So for patients with facial asymmetry, we have her final result here from a front view, which is our goal view, and then a 3/4 view. We also can treat an unsatisfactory reconstruction from usually any technique. Some patients came to us, this happens to be an adult who actually had a normal ear when he was born, had a traumatic accident and lost his ear, had 4 rib cartilage reconstructions from a surgeon, and was dissatisfied with the appearance. And so this is what he looked like after 1 operation. He came on, I think, to do a 2nd stage a little bit later. So when we talked about my philosophy as this being an art, you need to think about what are we mimicking or trying to sculpt. And you look around, and I'm sure all of you are experts at looking at people's ears now, but every ear is a little different, just like our noses, our eyes, and our mouths. And so it's important that the ears we reconstruct don't look all the same. So we do have a variety of PIERs. We're aiming for that goal. So here's a few quick examples of kids with different anatomy, different ears that we're trying to match, and different shaped ears. It's hard to gauge size, obviously, from all these little kids, but this boy had a very large ear to match, so this is one of my larger ears. She had a little ear, so that's her. And here you can see, those are all those same kids, but when you see the ears, all in one slide, it's a little easier to see that they're not all exactly the same. So here's where, since I'm going to be doing this for many years to come, I push myself. And I'm happy with my results, certainly, but they're not perfect. They're not close to perfect, and I'd like to get closer to perfect. So if I'm being critical of my own results, I'm going to go through a patient who I believe got a very good result. I was happy with his symmetry, and I think family's very happy, and he has a successful ear reconstruction. But let's really look at why this implant has some limitations and what can we do to improve them. The most obvious one to me, and I know I'm obsessive about this stuff, but the bowl is too small. It is not the right size for an adult, and that limits what I can do. So you can see on the normal ear, those shapes really don't look similar. Now, maybe not the average person would notice, but I notice, and it bothers me, so I consider that a limitation. In addition, the tragus is a struggle for me. I have to say, it's floating in space, three-dimensional, and has to look like there's a canal behind it, and I have always found that a big challenge. And then there's the area of the earlobe, and what I noticed in my results is sometimes that transition between earlobe and implant just wasn't smooth. You could tell there was an angle there, which bothered me. And then I could always tell that rim, to me, it looks too perfect, because your rim of your normal ears just isn't perfect. It's not the perfect same thickness or width. So when you just look at those, I get that it's subtle, but why aren't we striving to be as close as we can? So these two-piece implants that we've been putting together in this fashion, because we're melting or soldering two pieces of this MedPOR together, or Supor together, I only use Supor at this point, but for many years I used MedPOR, there's always a risk that these two pieces could separate or lead to a fracture. So I looked, how do we solve all these problems? And I won't say that I've solved them, but I have come up with a new implant, and it's the Lewin ear implant by my favorite company, Supor, who has allowed me to change the design and create what I want. This is not how the implant arrives to me, but this is what I carve on the table. So the thing about it is this is customizable to the opposite side, and it's a one-piece implant. So it essentially alleviates the risk of fracture. That's a big deal that I wanted to solve. And that's, I believe, going to be the case going forward in my career. I hope to never have another fracture. So this just shows an example of my daughter, Casey's ear, and a typical two-piece suprahelical rim, which is what I've been using for so many years, and comparing that to this new type of implant, the Lewin ear implant, where you can see I've tried to mimic the natural curvature. This is a little video that shows my two implants. They're both Supor, two pieces on the right, one piece is on the left. And one, my goal was to look handcrafted, hand-carved, and a work of art, so to speak. And the other is, you know, I love, and it's strong, and it's served me so well for a very long time, but my hope is that we can continue to push the envelope. So this is my first patient from day 0 to 1 year after surgery. Here he is with grade 3 microtia, day of surgery with his skin grafts in place, and then at 1 week where you have bruising and swelling. Oh, and gets to go to Disneyland after that. 2 weeks, you get to fly home, and the skin grafts are starting to be pink and look like they have a rich blood supply. At 3 weeks, we're applying ointment twice a day to help these skin grafts be nourished. And then by 4 weeks, we're getting a little more definition, and we don't need to wear a cup anymore because the ears, it's there. It is not coming off. 5 weeks, you can see that that scarring process is taking place, and you can still see plenty of scars. And by 6 weeks, you're going to be back to Swartz and back to swimming. Always a big, important question. And it just is a slow process. You have to understand that it just takes time for these grafts to really take on the characteristic of having normal skin color and feel. So this is at 4.5 months after surgery. And then we jump to 6 months after surgery, where you're starting to get a little, you still see scars, but you're getting a little closer. And here's 1 year out. And he was just, he's maybe just over a year out now, 1.5 years. So we'll continue to see improvement and change over time. But this is just a way to show you that even out through that 1 year time point, things continue to improve. So my feeling and hope that this Lewin ear implant will be a closer match to a normal ear. And what I really like is this shadow is super important. It looks like you have a canal even if you don't have a canal. This is a 3D image of a normal ear. It wasn't his normal ear, it was just a random adult's normal ear, but I think comparing side by side normal and reconstructive is so important for me to see where do we still have to improve. It creates a deep space. This I learned from my patients. I would get all these patients and they'd be, Dr. Lewin, why is it so swollen in the back? And I'm like, that's not swollen, that's the MedPOR implant, you know, for years and years. And I would be like, why do you care? It's the back of the ear. And then I thought, why aren't I listening to them? Like, they care because they're noticing that the back of the ear doesn't look like a natural back of the ear. And if you have very short hair, the back of your ear will be visible. So the way I designed this implant is a different way of stabilized on the head. And so that allowed me to have this really generous space behind the ear that more mimics what we see in the natural ear. So we also get a more realistic bowl because we're a little closer to what we were talking about before to getting a similar shape. So I'm going to try to go through some FAQs, and I'm probably going to rush a little because I think I'm way behind. If the Lewin ear implant is one size, how do you control the size? It comes more as a block form of an ear, and it gets customized and carved in the operating room. So here's a little girl who has one of these new implants that mom just sent me a picture. And here's another little boy where you can see the implant and sort of appreciate what we see behind the ear in the sulcus, which is the area we call that. So you can wear your glasses on top, etc. How do you know what size to make the implant? We've known for many years how the ear grows. That's very well studied. And at 3 years old, you're about 80% full grown, and 7, you're 90%. So we can predict based on your age what your ultimate size will be. And then how durable is the PIER? This is one of my patients from several years ago, but I love this video. The temporoparietal fascial flap that sits on top of the implant actually is mobile over the implant. So you can see that the skin moves all over, even though the implant stays the same. And similarly, the ear can move and come off the head or move back, quite mobile because it's not fixed to the scalp and it doesn't hurt. Right, Brennan? All right. So, similar to a rib cartilage ear, if you do this flap properly, it will heal like another part of the body. So this was 5 weeks after surgery. This child was bumped in a busy shopping mall, and all we did was butterfly tape it closed, and in perhaps a week or so, it healed on its own. You can see he doesn't have any residual issues with that ear. These ears are a little sensitive. They're not normal. They're firm and they are reactive. So if you get a bug bite or a bump or some such thing, these ears swell up and you just have to wait it out. We don't treat it. We never put ice on it, but it just resolves in a few days or a few weeks. So how long does a PIER last? Well, it's been around it's actually now 27 years. And rib cartilage has been around since 1959, so they're way ahead of us, but we still have a very strong track record in terms of our longevity. And this important point, which we mentioned a little bit earlier, is that living membrane flap and those skin grafts are yours forever. So this part of your ear will last a lifetime, and if you need to so-called upgrade to the latest and greatest, it is doable without too much trouble, obviously requiring a surgery. This is a young lady who's 19 years after her original MedPOR. I didn't do her original surgery, but she ended up with a fracture. She came to me, and she's probably 8 years after I fixed her ear, and pretty impressive from the original surgeon and how she's doing today. Many parents ask me, does the flap grow back? And the answer is no. Much like your appendix that may have to be removed when it gets inflamed, you take it away, you really don't miss it. It's not an organ that you need. This flap is not something you need as well. So it is, when it's gone, but there's other layers of fascia and even flaps that exist underneath it. So I used to do this surgery as early as 3, and this is a little patient of mine who I wanted the honesty of a 3-year-old. So here you go. This is Aaliyah, a little dark.
Okay.
Aaliyah, how old are you?
3.
You're 3, and did you have a big ear made?
Yeah.
Where? Where is your big ear? Over there. Oh, I see. Can I ask you a question?
Yeah.
Does it ever hurt your big ear
No.
that I made for you?
No.
Do you ever sleep on your new big ear?
Yeah.
And does it hurt when you sleep on it?
No.
No, not at all?
No.
Okay. Are you able to move your ear? Can I see? Come over here a little bit. Let's see. If we go like that, I'm going to move your ear. You tell me, does it hurt when I move your ear?
No.
That doesn't hurt?
No.
Okay, and the skin moves on your ear. Do you feel me touch it?
Yeah.
Really?
Yeah.
Awesome. Okay, thank you. Gotta love these cute kids. Another question is, can you combine the bone-anchored hearing device with a PIER? And the answer is yes, you can, with either the post or the magnet type of PIER, bone-anchored hearing device. You can do it at the same time, and there's no scarring, no additional scarring. Here's a boy that had that combination surgery before and after surgery. What's the advantage of early ear reconstruction? So this is just general observations that I've had over the years, but compared to my older patients, the younger patients seem to have a little less anxiety. They seem to tolerate the surgery, I feel, a little bit better. They get sort of a quick increase in self-esteem because they're like, oh my God, I have an ear. You know, they're not critically analyzing the shape of the ear. It's like, wow, I have something I never had before. They do get less exposure to the bullying and teasing, and one technical component is that the thinner flaps give better definition, and here is a slide that sort of shows a young kid's ear flap compared to like a 12-year-old's flap, and that was just 2 random examples. It's not true in every single situation, but it's just a general trend that I see. Is there an ideal age for surgery? I used to say no, there's no ideal age for surgery because you guys, every family is individual, and certainly whenever your family makes that decision is the perfect age for you. But then I'm like, well, if you're asking, I'm going to be selfish and tell you when my ideal age is. And it's 4 years old, and it just has to do with anatomy of these little people. There is like drops of blood loss on little people, whereas adults, you know, a harder case and a little more blood loss. And from the anatomic standpoint, this is just the time that is easiest for me to complete the surgery. And I like doing it before kids go to kindergarten. And although I used to do surgery at 3 years of age, I appreciated the research that came out of pediatric anesthesia literature that said we really don't know those long-term anesthetic effects on these young developing brains. So if you're doing an elective surgery, their recommendation was to wait until 4. So we've adopted that from them. What are the risks? Well, there are risks to all surgeries, and this is the list of the risks or complications that I track and follow for my patients, and we'll go through these. And I'm going to tell you, I have a very, very strong philosophy about risks. I'm a believer in transparency. I am not looking to hide anything. I told you our patient panel was random. There are kids with complications on that panel, and I'm not going to hide those from you. You should ask them about those because Risks don't happen to every patient, and I feel like my risk or complication rate is quite low, but they happen, and you sitting in this audience, it's my responsibility to teach you about those risks. So I don't hide anything, and what you do is I learned in medical school, you treat every kid, I think many surgeons do this, but you treat them as if they are your own child. And what that does for you as a surgeon, what I feel it does for me is, I may make a technical mistake, but it keeps me from making a judgment error. Because I know every step of the way, I'm gonna make the decision that I believe is in your child or my child's best interest. So what is an implant exposure? This is the significant one, and it's a hole where part of this implant is visible. And you can see examples. I mean, they're usually, in my practice, quite small, but you can actually see an implant there, and you can't leave it like that. And this slide, you can see, says requires surgical treatment, but guess what? We have new stuff that's very exciting. It doesn't always require surgical treatment. And we found a non-surgical treatment that we walk you through, and if I didn't actually see it with my own eyes, I honestly would not believe it. But this is a patient who had a clear exposure. That's the implant. It's right there. She treated it, just wound care, and it healed. It sort of blew me away, so now I'm going to show you a different patient. Well, in my practice and all my experience, this is looking to die. It is not happy tissue. Pink, healthy, happy everywhere else, but this is unhappy. So we started treatment of this area, and we waited, and it looked like, typically, if you asked a plastic surgeon, they would say, that skin graft's dying, it's dying because the flap's dead underneath, and you're gonna see the implant there. But I was super happy that all we did was wound care, and here we go. This is that same patient, and she healed up on her own. Patience, no rushing, just believe. So people talk about rejection. There is no rejection because this is, rejection's an immune reaction. It has to be to something living, like a kidney transplant. So you can't have rejection with a porous implant. Porous implant is this biocompatible product, and you can see in this micrograph that you actually have growth of tissue into the middle of the implant. So when people talk about rejection, what they mean is an exposure, but it's not the implant that's the problem. It's actually the tissue, that flap. And when that living membrane flap, like we said, isn't perfect, that's when you would have this issue. But if it's done properly, you'll have stability. So beware of critics, because there's a lot of myths. And this is my alma mater, so it makes me a little bit sad. But they talk about the advantages of MedPOR, which really isn't a graft, but it's an implant. And they do state the truth of it's one stage, earlier age, doesn't require a donor site, eliminates pain and healing from that donor site, and less variability in the cosmetic outcome. I think that's a pretty generally accepted statement. But when they talked about the disadvantages of MedPOR, they said a minor trauma could basically result in infection, exposure, and complete extrusion of the entire implant and complete loss of the ear. It's never happened. My entire practice, hundreds and hundreds and hundreds of ears, maybe 1,000 by now, and it's just not true. So it's out there, you read it, you believe it, but it's not the case for people experienced with the technique, at least. They also stated that, you know, the other problem is they're insensate, which means they don't have feeling. But the truth is that that little girl, and you can ask our patient panel, they get feeling almost right away after surgery, and again, as they go along, they get more and more. So that is not true. It seems that they're scare tactics. Infection's really important, not common, but here's a patient who had a very significant infection, but we were able to treat her just with antibiotics, which is the usual course. Fracture, you can see here, there's rim is usually where fractures occur, and this implant needs to be replaced because of this. Fracturing is just an inherent risk when you have to make this implant out of two pieces. So although it's not common, it does require surgery, so it is important. That 2013 redesign increased strength, but this is the only risk that over time will increase. Nerve injuries to eyebrows, we talk about this, it's a little confusing. It's very rare that it would ever cause a permanent injury, but you can have temporary weakness. It's just of the upward motion of the eyebrow. Doesn't affect any part of the face, doesn't affect downward motion. And if we know that the flap blood vessels are too close to that nerve, we take a different course. So in that transparency philosophy, I'll share with you the complication rates that we collate every year around this time. 356 consecutive patients. I do a bunch of surgeries on patients that have had previous failed surgeries, so they're not included because their rates are different. But you can see we've had about a 5.9, almost 6% exposure rate, just a 2% infection rate, and really kind of minor complications in the rest. So how can we decrease these even further? My goal is to have no complications, not really obtainable, but I'd like to get there as close as possible. So just being obsessive with attention to detail, having a ton of experience is very helpful. Controlling the environment like we do in our operating room. Learning from my patients, which have been my whole education, is just focusing on what my patients are teaching me and striving to innovate. My goal is perfection, even though we'll never get there, we should still be striving. So what's most exciting to me, and I don't have a good explanation, but we have done 72 of the Lewin ear implants now, and we have my lowest exposure rate of my career, 2.8%, and only one infection, which was actually just a few weeks ago. And so for me, those are significant improvements, but I'm not sure why. I don't really have the explanation. Time will tell, perhaps, but I only could come up with one theory, which has to do with the porosity of these implants. And if you look at the original implant, these areas are where we solder the implant to make it strong. Well, everywhere we've soldered these two implants together, there's no more pores, and so the membrane or the tissue flap can't grow into the ear, whereas this new one-piece design is 100% porous. I'm not sure if that is beneficial, but I certainly think it could be advantageous. So which comes first, ear canal or ear? So Dr. Kasser will tell you atresia repair comes first and PIER comes 6 months later. That's the least risky way to do it and allows me to control the position of the implant best while this canal's healing. There are disadvantages to PIER that you need to be aware of as well, which has to do with the long-term outcome being unknown after 27 years, that a hole, if you get one, may require surgery, that it's technically challenging, and very few surgeons are really dedicated themselves to this technique. You should ask your potential surgeon these following questions so you get an idea of exactly how much experience they have. And this last one, I feel, is really important. Before and after pictures of both ears. This is my pet peeve. You cannot judge an ear if you only see the one surgical side. Because an ear, this little sculpture, is only as valuable as it is to look like the opposite side. So if you cruise websites, they often only show a few examples, the best view only. They rarely show the normal ear. And I don't see a lot of close-up pictures. You can't examine and know what the skin and the scars look like if you're taking a full head picture and you're not showing what the ear looks like. So if a surgeon's not going to give you this, I mean, they may not have it on their website, but they should show it to you. Run, because that's not right. You need to know what you're getting. The neat thing about social media is it sort of takes all control away from surgeons. You can look on social media sites and parents are randomly posting pictures of their kids' ears. And that's great because that's how you are going to see your children's ears, randomly, from weird angles all over. So that's critical. So the future of microtia surgery, this looks familiar. So it has been 21 years since this very famous iconic picture of a mouse with its ear growing on the back of it. And we're not here yet. And it's unusual, but you hear these terms, bioengineering, stem cells, regenerative medicine, 3D printing, and everybody is actively working on getting us to that point. I'm going to spend just a couple minutes telling you about probably one of the most exciting developments I've seen in ear reconstruction. Just happened in February 2018, came out of China, and it's basically the first example of this dream that we've all had of using a kid's own tissues to build an ear. Like, this was done. So I'm gonna just be over my time a few minutes because I think it's important for you guys to know about this study. It was quite impressive, I will tell you, in just imagining it and then accomplishing it. So they start with a 3D image of the normal ear for a patient with microtia, and then they build what we call a reverse mold, so you can mold the opposite side to look similar. And from that, they use a complex type of materials called a PGA, PCL, PGA sandwich. And the mesh one is the scaffold. And they're gonna grow actual cartilage cells onto this scaffold in this mold to make a cartilage ear in the lab. And basically, you can see that they start with seeding this scaffold with the patient cells from the microtia cartilage, grow them up, put them in there, and 3 months later, they get this ear. And it's beautiful, and in fact, it looks a little bit like my, which was the goal, like my new implant. So here it is, and interestingly, it uses the same skin as well as fascia to cover it. So when we can do this, I feel like all the techniques I have been doing in PIER for so many years are going to be perfectly in play with these new cartilage frameworks. So here you can see at the end of the case, covered with ear, skin, and fascia. But this is the big question: scar. We don't know how to fix scar. Scar is our enemy as surgeons, and as beautiful as that implant was, when that scarring process takes place 2.5 years after surgery, the ear doesn't look exactly like the other ear, which is our goal. So we do have several hurdles, and you in the audience need to understand you're not going to want your child to be a guinea pig. I'm not going to let my patients be a guinea pig. So without that 5-year post-op data, you can't make that jump. So we are quite far, and then we still think, it's not really discussed, but you're sending off cells from your own child to a lab, and they're growing those cells up. How do I, as the surgeon, have any way to prove that they sent me my patient's cells? That's like a chain of custody that I need a lot of security that I'm not putting in somebody else's cartilage. If it's not all done in the OR that day, you have to have that trust factor, and it's disastrous if a human error occurs. So we have those hurdles. Teaser slide. Near-term future, can we get better than we are today? Well, we should. If we can capture a 3D image of the normal ear, and then we can use software to alter that based on basically my years of experience of how these implants respond, then we should be able to produce a framework specific to your child's anatomy. So, next year. Last slides, thank you guys. This is why I love my job, this little patient seeing her ear for the first time, and mom sending me several months later her school pictures side by side. This is a little famous guy. Oh, sorry, I messed that up.
Thanks. She's as nasty as you are.
Looks good. Swollen, red, purple, just the way it's supposed to look. Tiffany, Danny, they do look crazy like that, but that's okay. That's what they're supposed to look like. It actually looks just like the picture that I gave you. You have a big ear. It's probably too swollen.
Do you want to see your ear? Just don't touch it. What do you think? Do you see a big ear? Yeah. Is that crazy? Yeah, I know.
I got bigger now.
All right, last one.
I have 2 big ears. Thanks.
Oh.
I got so much ears.
Yes, you do.
This ear is awesome.
right. I'm a little over, not too bad. We're still giving you your break, I promise. 15-minute break, we'll resume right back here. And? And please, if you get a chance, visit our vendors over here and take a look at all their wares. They're pretty impressive. Thank you, guys.